Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to talk about liver failure. Liver failure is not only one of the common reasons of admission to intensive care unit, also is a frequent finding in critically ill patients who are already admitted to ICU. Here, I would like to focus on acute liver failure and acute on chronic liver failure, which are more relevant to intensive care medicine. Let's start with acute liver failure. Acute liver failure is a rapidly progressive and life-threatening clinical condition which occurs as a result of massive liver injury with parenchymal necrosis. It can be classified as hyperacute or fulminant, acute, and subacute. Differentiation between hyperacute, acute, and subacute liver failure depends on the interval from the onset of jaundice to the development of encephalopathy. Encephalopathy occurs within a week of jaundice, and the incidence of cerebral edema is the highest in patients with hyperacute liver failure. In acute liver failure, the interval from jaundice to encephalopathy is 1 to 4 weeks. If encephalopathy develops within 4 to 12 weeks after jaundice, then it is regarded as subacute liver failure. Now, I would like to discuss causes of acute liver failure. Drug-induced liver failure is mainly caused by paracetamol, NSAIDs, antibiotics, antiarrhythmics, for instance amiodarone, antiepileptics, for example sodium valproate and phenytoin, antituberculous drugs such as rifampicin and isoniazid, and recreational drugs like ecstasy and cocaine. Among these, paracetamol toxicity is probably the most common cause of acute liver failure in the UK. Alcohol excess could initially cause fatty liver and eventually liver failure. Infections which are related to acute liver failure are viral hepatitis A, B, and E, especially in developing countries, and herpes viruses like herpes simplex, chickenpox, cytomegalovirus, and Epstein-Barr virus in immunosuppressed patients. Leptospirosis should be considered in patients who have had contact with contaminated water. Inflammatory cause of acute liver failure, which is more common in developed nations, is autoimmune hepatitis. Rarely, hemophagocytic lymphohistiocytosis could be related to acute liver failure as well. Moreover, vascular events such as hepatic vein thrombosis, known as Budd-Chiari syndrome, portal vein thrombosis, liver ischemia, and hypoxia due to hypoperfusion, which could be seen in critically unwell patients with multi-organ failure, and trauma to the liver can result in acute liver failure. Malignancy, for instance carcinoma and lymphoma, could also lead to acute liver failure. Hereditary diseases like Wilson disease, hemochromatosis, alpha-1 antitrypsin deficiency, and cystic fibrosis should be taken into consideration in patients who have family history of liver disease. In pregnant patients, acute fatty liver of pregnancy and HELLP syndrome should be considered as the causes of acute liver failure. As I mentioned earlier, patients with chronic liver failure could be admitted to intensive care unit as acute on chronic liver failure with acute deterioration, which could be precipitated by sepsis, for example bacterial translocation by spontaneous bacterial peritonitis in patients with ascites, GI bleeding, dehydration, electrolyte abnormalities, sedative drugs, alcohol abuse, portal vein thrombosis, or liver tumor. Initially, patients with acute liver failure may appear relatively well, but they can rapidly progress to developed multi-organ failure. Prodromal symptoms such as nausea, vomiting, fever usually precede. However, they may not appear when hepatic failure develops quickly, as in paracetamol overdose or liver ischemia or hypoperfusion. Physiologically, as one of the major body organs, liver does lots of functions, including metabolism of bilirubin, platelets, clotting factors 1, 2, 5, 7, 9, 10, ammonia, and glucose. Therefore, if the liver starts to fail acutely, patients can present with jaundice, coagulopathy with usually INR more than 1.5 and bruises, flapping tremors, and hepatic encephalopathy. Hepatic encephalopathy can be graded from changes in behavior, sleep disorientation, lethargy, and confusion to stupor and coma. In extremists, it can progress to cerebral edema and brainstem herniation. Hypoglycemia must be actively sought, monitored, and treated as well. In addition to functions of the liver, which I mentioned earlier, liver plays a major role in metabolism of bile acid, protein, lipid, and hormones. Hence, in patients with acute and chronic liver failure, when such metabolisms are impaired, signs and symptoms of underlying chronic liver disease may be seen. These include pruritus, ascites, peripheral edema, muscle dystrophy, leukonychia, porotic swelling in especially alcohol-related liver disease, spider nevi, palmarythema, clubbing, loss of secondary sexual characteristics such as sparse axillary hair, gynecomastia in men, and breast atrophy in women. In patients with cirrhosis, features of portal hypertension like hepatosplenomegaly, ascites, edema, opening of portal cava anastomosis, which can lead to periumbilical veins, esophageal and gastric varices, and hemorrhoids. Hepatomegaly is particularly seen in alcoholic hepatitis and infiltrative liver diseases. A shrinking liver is a poor prognosis sign in patients with acute and subacute liver failure. Acute liver failure is often complicated by multi-organ failure because liver necrosis can trigger inflammatory cascade, especially if patients have underlying chronic liver disease. Aspiration pneumonia, pleural effusion, and pulmonary infiltrates due to ARDS are common in severe encephalopathic patients. In patients with portal hypertension, hepatopulmonary syndrome can occur due to pulmonary vasodilatation and AV shunts, resulting in hypoxemia and orthodesia. Portal pulmonary hypertension is another notorious complication caused by abnormal vasoconstriction with vascular remodeling, and patients could be at significant mortality risk after liver transplant. Furthermore, patients with acute and chronic liver failure characteristically have hyperdynamic circulation secondary to vasodilatation and hypovolemia, leading to vasoplegic cardiovascular collapse, which could be contributed by sepsis due to infections, hypovolemia following GI bleeding, diarrhea or diuretics, and relative adrenal insufficiency as well. Hypertension can also be caused by cardiac dysfunction in patients with cirrhotic cardiomyopathy or alcoholic cardiomyopathy. The most common causes of acute kidney injury in acute and chronic liver failure are usually pre-renal, such as sepsis, hypovolemia, and cardiac dysfunction, like I just mentioned. Besides, AKI can be related to hepatorenal syndrome, which is characterized by pre-renal-like deterioration in renal function with splenic vasodilatation and intense renal vasoconstriction. Renal blood flow could be impaired when there is increased intra-abdominal pressure by massive ascites, leading to acute kidney injury. Encephalopathy may be either precipitating factor or consequence of acute and chronic liver failure. Clinical cerebral edema is more common in patients with acute rather than acute and chronic liver failure. As we have got the presentation of acute liver failure, now I would like to talk about investigations. Serum liver function tests are simple tests performed as a blood test. In acute liver disease, the bilirubin level could reflect the severity of the liver injury to some extent, and a rising serum bilirubin concentration is particularly significant in patients with chronic liver disease. If the bilirubin level is high, it is important to measure the conjugated and unconjugated bilirubin to determine whether hemolysis is contributing to it. Alanine aminotransferase and aspartate aminotransferase are hepatic intracellular enzymes. Here, ALT is more specific for the liver. In acute toxic injury like paracetamol overdose and hepatic ischemia, the serum concentration of aminotransferase enzymes could increase to several thousand whereas in chronic liver disease, these levels may be just slightly increased or even normal. In alcohol-related liver disease, AST activity is frequently twice that of ALT, and gamma-GT could be raised as well. High gamma-GT levels can also be seen in patients with biliary obstruction. Please bear in mind that falling plasma ALT and AST levels in patients with acute liver failure do not necessarily mean that liver function is improving, especially if patients are clinically deteriorating with worsening jaundice, coagulopathy, and encephalopathy. It would rather imply that liver necrosis is massive and the liver volume is decreasing. Alanine phosphatase could be seen particularly in patients with biliary diseases and with infiltrative liver diseases. A low plasma albumin concentration may be a sign of deteriorating liver function in patients with chronic liver disease. However, in the intensive care setting, it is influenced by many other factors and cannot be used as a marker of prognosis or progression of liver disease. Ammonia, when tested, are usually raised in acute liver failure. Not only liver function tests, also abnormalities of full blood count are frequent. Pancytopenia occurs in hypersplenism. Macrocytic anemia could be a sign of alcoholism and nutritional deficiencies such as B12 and folate, and hypochromic anemia may be seen if there is chronic low-grade blood loss, for example in upper GI bleeding. Leukocytosis could indicate infection and eosinophilia in drug-related liver disease. Together with thrombocytopenia, prolonged INR is a significant finding of liver dysfunction, and it is unlikely to respond to IV vitamin K. In acutely bleeding patients with suspected DIC, we should add fibrinogen and do thromboelastogram for transfusion of blood and blood products. Non-invasive liver screening are done in addition to full blood count, INR, and liver function tests, basically to identify the cause of liver failure. The screen includes hepatitis and herpes virus serology for hepatitis A, B, C, E, cytomegalovirus, Epstein-Barr virus, herpes simplex virus, herpes zoster infections, leptospirosis serology in high-risk patients, autoimmune screens such as anti-nuclear antibody, anti-mitochondrial antibody, anti-smooth muscle antibody, and anti-liver kidney microsome type 1 antibody, immunoglobulin, ferritin and iron studies, ceruloplasmin, serum and urinary copper, alpha-1 antitrypsin phenotype, and alpha-fetoprotein. We also should check paracetamol level even if there is no known history of paracetamol overdose. Other basic blood tests such as creatinine, electrolytes, bone profile, and CRP should be done to keep an eye on renal function and inflammatory process. We should monitor blood gases, mainly for pH and lactate. Acidic fluid should be sent for cell count, gram stain, culture, and sensitivity for patients with spontaneous bacterial peritonitis. From radiology point of view, ultrasound abdomen is easy to assess liver parenchyma for fatty infiltration and abnormal area of deposits, biliary tree for dilatation, and also vascular supply of the liver to detect any arterial or venous occlusions and any perfusion abnormality. CT and MR imaging allow further detailed visualization, particularly vascular supply and possible areas of tumor infiltration. ERCP is useful in patients with biliary obstruction who will benefit from biliary decompression, as well as in patients with suspected malignancy to assess the pancreas and abdominal lymph nodes. Moreover, ERCP can identify bile leak or pseudoaneurysm following traumatic liver injuries. MRCP may be indicated if there is any evidence of bile leak. In liver failure patients who present with upper GI bleed, OGD should be arranged to figure out the cause of bleeding and treat at the same time if appropriate. Fibroscan should be requested for patients who are at risk yet have not been diagnosed with liver cirrhosis by liaising with gastroenterologists. Liver biopsy may be required in order to establish a diagnosis in patients who are suspected of having malignancy, particularly lymphoma, where systemic chemotherapy may be required. It is rarely undertaken in the critical care or acute setting due to high risk of bleeding in coagulopathic patients. The risk-benefit should always be considered. If liver biopsy is needed, it should be done under ultrasound guidance or by laparoscopic or transjugular route. Now, I have discussed the clinical presentation, causes, complications, and investigations of acute liver failure. I'll stop this video here. I hope this video is useful for you. If it is, please share with your friends and colleagues. In the next video, I will continue to talk about severity assessment, prognosis, and management of acute liver failure. I'll see you there. Take care.